Okay.
Good. How are you?
I'm good. Okay, welcome back to our second week, uh, day 2 of second week. Okay, good. Today, I'm going to take you through briefly about parathyroid gland disorder. So this is another endocrine disorder. So as you can see, the anatomical location from the diagram, the parathyroid hormone is located
Can't hear you.
posterior to
Sorry.
the thyroid gland. As you can see, like there are four. They are very tiny and very small, small gland. So they're located like on the top of thyroid gland, and they are very important gland, especially for regulation of calcium level in the serum. That is the principal function of this thyroid hormone in the body system. Okay, so the objectives for this session, at the end of the session, you are expected to know the physiology of calcium and the pathophysiology of parathyroid hormone disorder. And you need to know about the management of parathyroid hormone or parathyroid gland disorder. When you look at the gland itself, it is normally about the size of a grain of rice. You can actually even see it is very small in terms of size, like a grain of rice, 3 to 5 millimeter in diameter, and the weight is even very small. So most individuals normally they do have four glands situated posterior to the upper and lower lobes of the thyroid gland. That is why, as I mentioned, during thyroid surgery, the probability of inadvertent resection of the gland is very high. So this is a major problem. So what is the relationship between calcium and parathyroid hormone? Remember, parathyroid hormone is a hormone that controls the calcium level in the body system. So if the calcium level in the blood is low, what will happen? The gland releases, or if the gland normally senses the low calcium level in the serum, then it releases the hormone in the serum. So this PTH, when it is released because of low calcium level, then it can actually stimulate the release of calcium from the different parts, including the bone, into the bloodstream. And this ultimately increases the calcium level in the body system. So PTH increases bone resorption so that it increases the calcium level in the bloodstream. Then it also activates vitamin D production from the kidney so that it ultimately increases absorption of calcium from the intestine. So ultimately, when the PTH level is elevated, it increases the calcium level in the serum. So if the calcium level is too high, then what will happen? The negative feedback mechanism will be activated so that PTH will not be no longer producing in the gland. Then calcium, remember calcium, 50% of calcium is usually bounded to the plasma protein, mainly albumin, but it is usually the free calcium level is the one which is physiologically active in the body system. When you look at the parathyroid hormone, it is principally involved in stimulation of renal synthesis of vitamin D. So remember what we have discussed in the previous semester, vitamin D activation starts from the skin, from the UV light, but final activation will be carried out in the kidney. Especially the first hydroxylation is carried out in the kidney, but the 25th hydroxylation will be happening in the liver. So if someone is having a problem of liver and kidney problem, it will affect the activation of vitamin D, so that vitamin D will not be physiologically important. Then apart from that, the hormone can increase distal reabsorption of calcium. Yeah, that is another role. So it is very important to increase reabsorption from the kidney. Then apart from that, it decreases proximal and distal tubular reabsorption of phosphate. So paradoxically, it actually promotes the excretion of phosphate, but increases calcium reabsorption from the kidney. Then when we look at the effect on the bone, the gland or the hormone stimulate osteoclasts, then this ultimately promote bone resorption. So those are the principal role of parathyroid hormone in the body system. So this is, in fact, the summary of parathyroid gland, especially in terms of regulation of the calcium. So you can see if the calcium level is low in the serum, what will happen? There are some kind of calcium sensing receptor in the gland. So this senses normally low calcium level in the serum. Then the signal will be activated. So what will happen? Now the gland will produce more of the hormone so that it actually affects the kidney and the bone to increase the calcium level in the serum. So when the PTH is elevated, what will happen? It activates vitamin D activation from the kidney by activating what? First hydroxylation, so that when vitamin D is activated, mostly it promotes intestinal absorption of calcium. So this ultimately increases the plasma calcium level. Then apart from that, the kidney stimulates reabsorption of calcium and also inhibit reabsorption of phosphate. So this is like the function of the kidney, so that when the PTH activated, it actually kidney will be activated to reabsorb more calcium, and this ultimately increases the calcium level. Then apart from that, when you look at the effect on the bone, when the hormone is increased, when the hormone production is increased, it stimulates bone resorption so that the dissolution will release calcium, then this ultimately increases the serum calcium level. So this is the normal calcium regulation in the body system. Then what will happen when the calcium level is sufficient in the body system? Now, the calcium normally sends a signal that is a negative feedback mechanism to inhibit the release of the hormone from the gland. So now the calcium will no longer, or the PTH will no longer produce significantly because of sufficient level in the serum. So this is how the normal regulation in the body system can happen. Then in fact, when the calcium level is very high, what will happen? The parafollicular cells of the thyroid gland is also involved in calcium regulation, mainly calcitonin, the hormone that is produced from the thyroid gland that can actually inhibit the high calcium level in the serum. So remember, thyroid hormone is also involved in the regulation of calcium metabolism. So by mainly it is mediated by calcitonin. So calcitonin, when it acts on the kidney, it promotes excretion of calcium. When it acts on the bone, it prevents dissolution of the bone. So ultimately, this decreases the calcium level in the serum. So when it is significantly reduced, now the negative feedback mechanism will be activated so that the calcitonin effect will be withdrawn from the gland. So this is how the calcium can be regulated in the body system. So any derangement in this regulation, or maybe any problem in the gland, like parathyroid gland, can actually cause calcium disorder. So in short, when we are talking about parathyroid gland disorder, we're actually referring to a disorder of calcium regulation. So you'll see the patient will encounter having significant problem as a result of high calcium level and low calcium level. So generally speaking, parathyroid gland disorders are classified into two major categories: hyperstate and hypostate. So hyperstate, Now the gland is producing more of the hormone, but in hypo state, the gland is actually not able to produce sufficient level of the hormone. So the patient will end up having, like in hyper state, the patient will end up having high calcium level. Then in hypo state, the patient will end up a low calcium level. So this electrolyte imbalance with calcium will actually encounter, or the patient will have so many complication depending on the type of imbalance. So when you say parathyroid gland disorder, we are talking about the dysregulation of the calcium metabolism in the serum. So we'll discuss in detail. Let us see first hypoparathyroidism, or in short, hypocalcemia. I hope you remember what we have discussed in the last semester when we were discussing about electrolyte disturbances. We have seen about the calcium metabolism. So hyperparathyroidism, it is a clinical state due to the failure of the gland to secrete the hormone, or the failure of the action of the hormone on target tissues. So this failure can actually cause a lot of devastating metabolic disturbances as a result of deficiency of calcium in the serum. But what causes the glandular failure? So mostly surgical resection of the thyroid gland is the most common because of anatomical proximities. Then apart from that, when someone has done any resection due to adenoma of hyperparathyroidism, or any neck exploration can actually cause hypoparathyroidism. But of course, anatomy disease can also cause destruction of the gland. So those are the principal etiologies of hypoparathyroidism. Remember, this one is very notorious. So what will happen when the calcium level is very low in a certain individual? Remember, I will take you through about the normal calcium level later on when we are discussing about the investigation. So when you look at the clinical feature, most of the clinical features of hypoparathyroidism are due to low calcium level. So mostly when the calcium level is very low, numbness and tingling in the extremities and including the mouth is very common. Then apart from that, when the calcium level is very low, what will happen? The tissue will undergo hypersensitivity, and this hypersensitivity leads to depolarization. So as a result of depolarization, the patient can have muscle spasm known as tetany. Have you seen normally how like the hand of this patient look like because of hypocalcemia? So twitching and spasm of the muscle, including the finger and the hands, are very common when a patient is having this condition. So I don't know whether you encounter a case of tetanus. So it is more or less similar when a patient is having this problem. So muscle spasm or tetany is very common because of excitation of the tissue. Then apart from that, when the calcium level is very low, now there is depolarization because of hypersensitivity of the extracellular tissue. So the patient can actually even develop epilepsy or maybe a seizure, and irritability can also happen. Then apart from that, we'll discuss more when we're discussing about the eye and ocular disorder, like fifth year, last semester. Cataract is also very common when someone is having prolonged hypocalcemia. So what will happen when the calcium level is very low in the extracellular environment? There is damage of the membrane. This ultimately even allows influx of more sodium. Then the patient will end up having developing cataract. So cataract is just like is there anyone who came across a cataract? So like the lens part of the eye will be covered by any whitish like metal, which is actually like very common in older individual. So there are so many causes. Even high cholesterol level can cause cataract, but low calcium level also can cause cataract. Even high calcium level can cause cataract because the calcium binds with the phosphate. So this can actually crystal can cause deposition in soft tissues, including conjunctiva. So that is why cataract is very common, but this one is more of because of the damage of the membrane, and ultimately it can cover like exogenous materials in the eye, and it can cause loss of vision. In fact, this is the most common cause of loss of vision in older or geriatric population. For detailed information, we'll discuss when we read there. So those are some of the clinical picture when someone is having this problem. Then apart from that, there are two signs, Chauvistic sign and Trousseau signs. Those are very common signs when someone is having hypocalcemia, but they are not common tests in the practice. Huh? So this one, when you tap actually the facial nervus, which is cranial number 7, when you tap it, you'll see facial spasm because of hypersensitivity. So this one is very common, as you can see from the diagram, when a patient is having hypocalcemia. Even when a patient, like in this sign, there is a spasm of the hand when the blood pressure curve is inflated above above this point or above the systolic blood pressure. Now there is hand spasm can happen. Those are the most common tests and very common when a patient is having hypocalcemia. But I have never seen when they are doing these tests in the practical setting. So mostly they just rely on other clinical features as well as measuring the serum calcium level. So how do we investigate whether the patient is having hypothyroidism? Did I pass? Okay. Okay. How do we investigate when a patient is having hypothyroidism? Hypoparathyroidism is we can look at the serum calcium level is very mostly important. But remember, there are several causes of hypocalcemia. But one cause is hyperparathyroidism, but the other cause could be renal failure. And even the other cause could be maybe like low intake of calcium containing diet. So hypocalcemia associated uh, is usually undetectable or low plasma level of PTH. But mostly when a patient is having hyperparathyroidism, when you look at the serum calcium level is usually very low and the PTH level is usually undetectable or low in the plasma. So these are the normal values. So the level of PTH in the serum is usually between 10 to 65 picogram to picogram per ml. So if the level is actually below this reference range, we can say the patient is having hypoparathyroidism. Then, of course, we can look at even the total plasma calcium level. This is the normal reference range between 8.5 to 10.5 milligram per deciliter. Then, apart from that, one thing to note when a patient is having this condition is when we are measuring the serum calcium level, mostly the corrected calcium level is very important. Remember, more than 50% of calcium is usually bounded to plasma protein. So if someone is having any disorder associated with liver or anything that can actually deplete the plasma level of albumin, the probability of having low calcium level is actually very high because of that. So this one can give you a false result. Because of this reason, you need to correct the calcium level in this formula. So this is the corrected calcium level is normally will give you an idea about the exact amount of calcium in the extracellular environment. So you just factor in the calculation about the albumin level. So if albumin is very low, definitely the total calcium level can be low, but that is not real. That is not real. So that is why corrected calcium level is very important. Then apart from that, it is good to check whether the patient is having high phosphate level, because high phosphate level can also cause can actually cause hypocalcemia. So because of this reason, those investigations are very important to find out the causes of hypocalcemia in that patient population. So this is all about the investigation. So mostly we're going to look at the calcium level and the parathyroid hormone level. Then, how do we treat? How do we treat this condition? If a patient is having hypoparathyroidism, so how do we treat? So far, the treatment were available in the market is usually replacement therapy. If a patient is having very severe acute hypocalcemia, initially you give them calcium gluconate. So what do you know about the calcium gluconate intravenous administration? Do you recall, or what is the other indication of calcium gluconate apart from hypocalcemia? Sorry?
Hypercalcemia.
Yes, hypercalemia. Thank you. So in hypercalemia, it actually stabilizes the cardiac effect of a high potassium level, because high potassium can actually depress the myocardial tissues by causing hyperpolarization. So contractility is actually the biggest challenge when the potassium level is very high. So that is when we are going to give. But of course, in severe cases of hypocalcemia, we can also give calcium gluconate intravenously. So this is when we are going to have severe tetany as a result of hypocalcemia. So if the patient can swallow, oral therapy is usually recommended. But sometimes if the patient is not responding with the first dose, we can actually even give additional dose, 20 ml of 10% injection should be added when a patient is not responding. Then apart from that, there is a possibility of having hypocalcemia as a result of magnesium deficiency. So that is why, in case if the patient is not responding to calcium gluconate, now you have to check whether the patient is having magnesium deficiency, because magnesium is very important electrolyte that can activate or promote the secretion of the PTH from the parathyroid gland. So in case if the patient is actually having magnesium deficiency, what will happen? The gland will not secrete PTH. Then this ultimately causes hypocalcemia. Because of this reason, the plasma magnesium level should always be measured in a patient with hypocalcemia, and if low, magnesium therapy should be initiated. So this is how we are treating in acute condition. In acute condition, give intravenous calcium gluconate. Then if no response, you can add 20 ml of 10% calcium gluconate can be considered. Then if not responding, look at the magnesium level in the serum. But for maintenance treatment, mostly we are going to use vitamin D preparation. Remember about the importance of vitamin D. They are very important to increase intestinal absorption of calcium, which can be obtained from diet. Then in conjunction with calcium supplementation. So you give them calcium and vitamin D so that it can actually promote, like vitamin D will promote the intestinal absorption of calcium, so it can actually correct the the problem. So this is how we're giving maintenance treatment. Remember, there is a scenario we can consider intravenous parathyroid hormone therapy, but mostly because of cost and availability issues, PTH hormonal therapy is not a practical approach. But if it is available, it can be considered, but it is not very common when a patient is having this condition. So because of this reason, for chronic and maintenance treatment, mostly we are going to use vitamin D preparation along with calcium supplementation. Remember, we do have so many vitamin D preparation, like ergocalciferol, which is vitamin D2. We do have even calcitriol, which is active form of vitamin D. We also alpha calcidol is also another vitamin D analogs. Huh? Okay, then when we look at the ergocalciferol, which is like the inactive form of vitamin D2, I can say it is a prodrug because it requires activation. So the major problem with this ergocalciferol is difficult to use. It has longer pharmacological and biological half-life. So it will take actually longer time to restore the normal calcemia. So because of that reason, and it actually even persists for more than up to 4 months following withdrawal. So because of that reason, this ergocalciferol is not commonly used. But the other calcitriol and any other synthetic vitamin D analogs are commonly used. Like this one, for example, it can restore the normal calcemia level within a week time. Like within a week time, it can actually restore, but its effect only persists for 1 week following withdrawal, which is very good. So it is very easier actually to do manipulation because like effects can be reversed within a week, then it can be actually effects can be withdrawn following 1 week of withdrawal, and this is the usual doses. Huh? But of course, we need to monitor until the patient is normal calcemia is attained. Then after that, we can actually do it every 6 months. So most likely, when a patient is having hypoparathyroidism, mostly lifelong treatment is very important. As long as the gland is not working efficiently, the probability of having calcium deficit is very significant. So remember the ergocalciferol and cholecalciferol, they require renal and hepatic activation. They are not even activated in the liver and in the kidney. Because of that reason, they require usually activities, and that is why they require longer time to see the effect. But this one, alpha calcidol, is equivalent. It is actually hydroxylated in the kidney, 1 alpha. So what is remaining is activation in the liver. Remember, 1 alpha hydroxylation is usually happened in the kidney, but the 25 hydroxylation is usually occur in the liver. So that means if the vitamin D analog is hydroxylated at one functional group, means that is already activated in the kidney, and to be fully active, it requires hydroxylation at the 25 position. That is why when you say calcitriol, this is active and it does not require any metabolic activation. So this is the difference in between the two, so that you need to differentiate between. So when you say between vitamin D analogs, so like those 1, 2, and 3, they are prodrugs, but calcitriol is very active. It can be given immediately without even having any need of hepatic activation, renal activation. So especially if a patient is having maybe liver problem or kidney problem, this calcitriol might be very or like the drug of choice because of if the liver is deranged, it cannot actually activate calcitriol effectively, so that this drug will be the drug of choice in the treatment of this condition. So this is how we're managing hypoparathyroidism. So in severe case, replace with calcium gluconate. Then in chronic treatment, you just give vitamin D, analogs with calcium supplementation. So that is the most common recommendation. Maybe if you allow me, I do have a very short video, like 2 minutes maximum, 2 or 3 minutes, so that it can give you like the whole picture of hyperparathyroidism. Sorry, hypoparathyroidism. I'm just opening. Let me stop sharing. Then I share the other one. Can you see the screen?
Yes.
Yes.
Okay. Can you hear the sound?
Hypoparathyroidism is a rare endocrine disease that occurs when low or inadequate levels of parathyroid hormone, or PTH, are secreted by the parathyroid glands in the neck. The most common cause is injury to the parathyroid glands during neck or thyroid surgery. The condition is considered chronic when low levels of calcium and PTH persist for at least 6 months after surgery. Symptoms can include fatigue, muscle cramps, tingling and twitching of muscles, brain fog, anxiety, and reduced quality of life. More serious complications, such as cataracts, ischemic heart disease, and impaired renal function can occur in chronic hypoparathyroidism. Standard therapy includes calcium and vitamin D supplementation. However, some people remain symptomatic despite treatment and may require higher doses. There are concerns about the prolonged use of higher doses, particularly with regard to hypercalcemia or increased urinary calcium, kidney stones, nephrocalcinosis, and declining renal function. ESE guidelines now suggest considering monitoring of urinary calcium excretion at regular time intervals over a 24-hour period. PTH is critical in maintaining mineral homeostasis in the body through its effects on bone, kidney, and the intestine. As part of this process, the kidney plays a central role in regulating renal calcium absorption and phosphate excretion and activating vitamin D. Abnormal serum calcium concentration, hypercalcemia, and increased phosphate and calcium phosphate concentration increase the potential for serious comorbidities. It's not fully known what causes the long-term effects of hypoparathyroidism on the kidneys, and whether this is due to severe or long-term disease progression, standard treatment, or both. Further research is needed to understand exactly how hypoparathyroidism causes long-term kidney complications. New and continuing clinical research is expanding our scientific and real-world knowledge of this. With an extensive program of life sciences research and long-term data generation, Shire, as a leader in rare diseases, is committed to making a meaningful difference for people with conditions such as chronic hypoparathyroidism.
Okay. So this is just like a brief summary. I think by now you do have you actually capture the most important information you are supposed to know, and especially the causes is more of related to something that can cause exploration of the parathyroid gland. Okay, now let me take you through hyperparathyroidism. So hyperparathyroidism is the opposite of hypoparathyroidism. So this one is mostly due to increased production of the hormone by the gland. So primary hyperparathyroidism usually causes hypercalcemia. So remember, when you say primary, it is referring to like the problem is from the gland itself. So secondary hyperparathyroidism also reflects in physiological response to hypocalcemia as well as hyperphosphatemia. Do you remember? Okay, what will be the probable secondary causes, secondary hyperparathyroidism? Can you give me some example of secondary causes of hyperparathyroidism? If you remember, we have covered some information in the previous semester. Primary causes hypercalcemia, high calcium level, but secondary hyperparathyroidism reflects a physiological response to hypocalcemia or hyperphosphatemia. You remember about what we have discussed? Secondary hyperparathyroidism as one of the complications of CKD, where the kidney is failed, like it is not able to effectively absorb calcium. So as a result of low calcium level in the serum, now the gland will sense a low level of calcium. Then this ultimately causes hyperplasia of the gland. Then when the gland undergo hyperplasia, it cannot actually even like it cannot sense any negative feedback mechanism. So it will be continuously activating. So most of the time, the secondary causes of hyperparathyroidism is mostly as a result of physiological response to low level of calcium or high level of phosphate. Remember, even when someone is having kidney problem, they do have high phosphate level because the ability of the kidney to excrete phosphate will also be significantly reduced. So because of that reason, the patient will end up having hyperphosphatemia. So this high phosphate level activates the gland to produce more of the PTH so that this PTH can remove the, the absorption of phosphate from the body system. So this is secondary is more of like physiological response due to low level, but the primary is usually causing high calcium level. So you have to know the difference between primary and secondary hyperparathyroidism. So when you look at the epidemiology of this condition, but they generally speaking, parathyroid gland disorder is not very common disorder unless the patient is having any underlying causes such as renal failure, maybe reduced intake of vitamin and C. Otherwise, in normal individual, it's very unlikely to see this disorder. Incidence rate is 25%, 25 cases per 100, oh, is it 1,000? Yeah, 10,000 population per year. This is the study in the US and Europe. The incidence is very common in women than men, but I don't know why it's very common in women. And it's most common third and fifth decade of life, but most probably it is associated with the chronic condition is very high in this age of life. So like third and fifth decade of life. So this is the most common age groups or age classification of hyperparathyroidism prevalence. So when you look at the etiologies of hyperparathyroidism, the primary hyperparathyroidism is mostly due to adenoma of the gland. Remember, the glands there are four in number. There are actually two of them in the upper lobes of the thyroid gland, two of them at the lower lobes of the thyroid gland. So the primary causes of hyperparathyroidism is mostly due to adenoma of the single gland. So if there is adenoma in one of the gland, the probability of having hyperparathyroidism is actually very common. So like more than 95% of the causes of primary is usually adenoma of a single gland. But really, like less than 5% of the patient, hyperpressure of all the four glands will cause primary hyperparathyroidism, but mostly adenoma in a single gland can actually cause hyperparathyroidism. So this one is mostly the major causes of primary hyperparathyroidism. So when you look at secondary hyperparathyroidism, What causes hyperpressure of the gland? And chronic renal failure is the commonest cause. So that is why when a patient is having chronic renal failure, you need to assess the probability of having secondary hyperparathyroidism, and mostly the patient will have like bone manifestation is very common, including bone pain, weakness is very common due to osteoporosis as a result of hyperplasia of the gland. So secondary causes chronic renal failure is the commonest cause, and vitamin D deficiency is also another causes of secondary hyperparathyroidism. Okay, so then renal failure, we have already mentioned early stage hyperphosphatemia stimulates PTH secretion. But in advanced stage, the major problem is usually there is reduced hydroxylation of vitamin D. Then this ultimately reduces calcium absorption in the intestine. Like dietary calcium usually requires vitamin D for absorption. Then hypocalcemia and further stimulation of the gland is very common. So in the early stage, what causes, or in the early stage of renal failure, what causes the stimulation is usually hyperphosphatemia. But in advanced stage now, it is beyond the capacity of the kidney to hydroxylate the vitamin D so that the calcium level will be significantly reduced, so that this can further stimulate the hyperplasia of the gland. Then tertiary hypoparathyroidism is referring to like as a result of secondary hyperparathyroidism, then the gland undergo hyperplasia. For example, indistinct renal failure is the major cause of tertiary hyperparathyroidism. So what will happen in the indistinct renal failure? Now the kidney is no longer functioning at the organ at this level, so it is no longer working its function. So what will happen? There is hyperplasia of the gland. Now the gland become autonomous, and there is excessively producing the hormone and rising the calcium level. So it becomes autonomous and it is no longer responding to the negative feedback mechanism. That is, we call it tertiary causes of hyperparathyroidism. So these are the etiologies, but remember the secondary ones are comparatively the most common type of hyperparathyroidism. Yeah, the result of chronic renal failure. Then, what are the most common clinical presentation when someone is having hyperparathyroidism? Remember, high level or hyperparathyroidism is associated with high calcium level. So what will happen when the calcium level is very high in the serum? Anorexia and weight loss is very common. Then polydipsia. Yeah, it actually has some kind of osmotic effect when the calcium level in the serum is very high. So the patient will end up having polydipsia. Okay, then when we look at the mental status change, there is poor concentration, suppressed memory is very common. Then when the calcium level is very high, it can actually activate the vomiting center. Nausea, dyspepsia, and vomiting is very common. Then I think polydipsia is mainly because of the dehydration. So the patient will having actual excessive interest to take water, constipation, hypertension. Then when the calcium level is accumulated in the kidney, it can actually cause renal stone. That is why if you remember from the video, when we continuously administering calcium without monitoring, the probability of having kidney stone will be very high, because calcium can actually precipitate in the urine and form a stone, and they can actually block the renal tubule. That is why renal stone comes in. Then this calcium can actually form deposit in soft tissues, mainly in the conjunctiva and cornea. Then it can actually cause even cataract or calcium deposit in the conjunctiva and corneal. This ultimately even causes loss of vision as well as inflammation in the eye is very, very common. Then bone pain and deformity. Remember, when the gland is undergo hyperplasia, it can actually continuously eroding the bone. So this actually causes reduced the minerals in the bone. So the patient will end up having deformity in the bone as well as pathological fractures. So those are the major complication or manifestation when a patient is having this problem. How do we investigate? So hypercalcemia is the primary biochemical abnormality in primary hyperparathyroidism. Remember here, in the primary hyperparathyroidism, the problem is adenoma in the gland. So mostly the patient will end up having high calcium level. Then decreased phosphate level. Yeah, there is a possibility of actually having decreased phosphate level. So this decreased phosphate level is due to when the gland is producing more of the hormone, it actually promotes the excretion of phosphate from the kidney. That is why the phosphate level is usually low. Then the PTH level is usually elevated. So the PTH level is usually elevated in most of the cases here. The PTH level is usually elevated in most of the cases. So that is why the patient is having high calcium level. Okay, for example, for tumors like neck ultrasound, CT, and MRI scanning is very important. So that we can rule out whether the patient is actually having a tumor in the gland or not. So this is the most common investigation we need to look at. Then, apart from that, there are many other causes of by the hypercalcemia, including malignancy. Remember, we have seen about several causes of hyperparathyroidism. But in terms of calcium level, there are so many causes. For example, multiple myeloma. Multiple myeloma is, we'll discuss when we are reaching about cancer. Multiple myeloma is the plasma cell disorder. It's just a plasma cell malignancy. So that means the body is producing more of the beta cell, which is primarily producing antibodies. So this this beta cell malignancy can actually produces a lot of cytokine that can actually even activate osteoclastics in the bone. So they promote osteoclasts. So the cytokines that is produced by myeloma cell, they actually produce, they do have osteoclastic activities. That means they can activate osteoclasts. And apart from that, some myeloma cell produces parathyroid hormone related peptides. So these PTH related peptides they can actually work as like that of parathyroid hormone so that they promote excessive production of the calcium by causing bone resorption. So myeloma cell, in short, they can promote osteoclasts so that they can increase what? Calcium level. But in such a scenario, by the way, remember, the PTH level can be undetectable. So the PTH level is normal, but the calcium level is very high. So this is something, there is that's something that causes other than what we have discussed so far. Then, for example, like drugs, thiazide diuretics. If you remember, thiazide normally promote, they prevent the excretion of calcium and they cause hypercalcemia. Then maybe excessive vitamin D replacement can cause hypercalcemia. Thyrotoxicosis. Remember, thyrotoxicosis promote osteoclasts. So the patient will end up having high calcium level. Immobilization. Immobilization by they promote osteoclastic activity. So those parameters should be excluded when you are investigating the causes, because there are several causes. Hypercalcemia can be due to primary disorder in the gland, could be secondary disorder such as renal failure, could be because of malignancy, could be because of drugs, could be any other endocrine condition such as thyrotoxicosis. But remember, in most of the cases, when a patient is having those cases, the hormone level is usually undetectable, because the high calcium level that is produced as a result of this condition can suppress the gland significantly, so that it ultimately reduces the level of PTH to undetectable level. So did you notice the difference between the other primary hyperthyroidism and other causes of hypercalcemia? Did you notice the PTH level is mostly elevated in other causes, but this one is significantly undetectable because of long-term suppression as a result of high calcium level. So did you note the difference? Any feedback? Okay, so I'm assuming normally you capture what I said. Okay, then when you look at treatment-wise, treatment of hyperparathyroidism, the primary treatment is usually surgical removal of the adenoma. That is the only curative treatment approaches. So if the patient is actually having adenoma in the gland, surgical resection will be the curative approaches, because it is adenoma that causes increased production of the hormone. So the main indication for surgical resection is mainly when a patient is having persistently hypercalcemia, of course having adenoma, then symptomatic hypercalcemia, renal impairment, renal stone, progression of osteoporosis. So those are the primary indications of surgery in primary hyperparathyroidism. Then around 10% of surgically treated patients develop permanent hypoparathyroidism. So when you look at it, 10% of surgically treated patients develop permanent hypoparathyroidism after surgery. That is the major problem. Then how do we treat in ways hypercalcemia? So severe hypercalcemia is a medical emergency, remember. When the calcium level is very high, it is a medical emergency because of the complications what we have seen before. So normal saline plus loop diuretics, they can actually promote excretion of the calcium level, but the biphosphonate, the calcitonin, gallium, and other medications, they mostly reduce the bone resorption. So mostly they're important to prevent bone resorption. But of course, glucocorticoids can actually even reduce gastrointestinal absorption of calcium, so they can be considered sometimes. Intravenous EDT or phosphate can be considered, so that it can form chelation. Then in severe form, maybe dialysis can be considered to remove the excessive calcium in the serum. So non-pharmacologically, this condition can be treated by calciuric agents such as normal saline. Then, apart from that, if the patient is actually immobile, we need to require the patient to ambulate as much as possible, because ambulation should be initiated, because mobility enhances bone resorption and ultimately increase the calcium level in the serum. That is another important point to note. So we need to discontinue any calcium supplementation with the moment we encounter the patient is actually having high calcium level. That is another important recommendation. Then, as I mentioned before, when the loop diuretics furosemide can be considered. So this one is maybe added to hydration once the rehydration has been achieved to avoid fluid overload and enhance renal excretion of calcium. So this can be considered as a pharmacological therapy, but the biphosphonates, remember we have mentioned, I don't know whether we have mentioned about the biphosphonate before. The biphosphonates they're very important in the management of osteoporosis, especially when someone is having bone resorption. So they are very anti-resorptive therapy of choice for hypercalcemia of malignancy, especially if the patient is actually having hypercalcemia due to malignancy. If a patient is having hypercalcemia due to malignancy, this is a drug of choice. But the major problem with biphosphonate is they do have like poor bioavailability and only IV agents should be used in case of very like urgent condition. We can give them orally, but the absorption is very poor. So because of this reason, mostly they should be initiated at the time of the diagnosis because of the delayed onset of action. That is a major problem. Then let me ask you one question. What special advice can you give the patient when a patient is taking biphosphonate orally? What special instruction can you give to the patient when a patient is actually taking oral biphosphonate? Amina? Amina, can you hear? Okay, Bosibori? Patel? Is there anyone who can hear?
Yes, sir.
Pardon the question.
Okay. What when a patient is actually taking biphosphonate, like zoledronic acid, orally, there is a special instruction we need to give the patient. So what special instruction can we give to the patient when they are taking this class of drugs?
Um, Sir, is it related to like muscle or joint pains?
Okay, not really, because what if like what is the essence of okay? No, there is not really. There is a special instruction we need to give them, like if they are taking biphosphonate orally.
Take it
Is it,
an empty
it should be
stomach.
given on an empty stomach.
Why? Why it should be given on an empty stomach?
Maybe to increase bioavailability because
Yeah,
it
it should
has
be given on an empty stomach so that we can enhance bioavailability. That is one possibility. Eh? Any other special instruction? That one, it is mandatory. So, like the moment we give them, we have to give that instruction. Otherwise, the patient encounter one kind of ADR. Just find out. Eh?
They should clean their mouth.
Uh-huh.
Is it that one?
Cleaning their mouth.
Mm.
Why?
Do they cause osteoclast? Something related to that?
No, they don't cause osteoclast. That is why if they are causing osteoclast, means they are promoting high calcium level. So, okay, because of time, just let me tell you. Biphosphonate, by the way, the major problem with biphosphonate, the tendency to stick to the esophagus is very high. Then after that, it can cause pill esophagitis. Like pill, P-I-L-L, then right esophagitis. So the major problem with this class of drugs, by the way, they can stick to the esophagus, then causes pill esophagitis. So the patient, when a patient is taking this medicine orally, we need to give proper advice. Take adequate amount of water. Make sure you have to be in a standing position at least for 30 minutes after you take this medicine. Otherwise, the probability of sticking to the esophagus is very high, and it causes pill esophagitis. So plenty of water, standing position for minimum of 30 minutes after taking the biphosphonate is usually recommended to prevent the inflammatory reaction as a result of the sticking to the esophagus. That is a very important point. But as someone said, even empty stomach administration is very important because food usually delays the absorption of biphosphonate. So this is really the most common drugs by the, especially in the management of hypercalcemia of malignancy, is commonly recommended. Then, in case the other pharmacological molecules, what we have seen, they do have a delayed uh, onset of action. So if you want to have like immediate effect, calcitonin is a drug of choice. Intravenous calcitonin is the drug of choice because onset of action is usually very rapid. So it can reverse life-threatening ECG changes of arrhythmias and CNS effects should be given immediately. So mostly this is a recommendation if it is available in case of emergency condition. But gallium nitrate can also be used, but because of renal nephrotoxicity, the use is usually very limited. So in summary, when a patient is actually having high calcium level due to uh, due to uh, due to hyperparathyroidism, if it is primary, you just resect, but resection might not be possible in all settings. So we have to actually treat symptomatically. Calciuric therapy is normal saline with Lasix. Anti-resorbative therapy, we can use the alendronic acid, corticosteroids, and calcitonin and gallium nitrate can be given. So can you see even the onset of action of zoledronic acid? They usually start 24 to 48 hours later. Can see calcitonin starts to work 2 to 4 hours after administration. Yeah, that is essence of giving calcitonin when a patient calcium level is very significantly elevated. Okay, maybe let me share you like one a small video. Then we do have like practice questions so that we can do it together. First, let me show you the summary of hyperparathyroidism.
Managing your projects should feel more like this. That's why you need ClickUp. With ClickUp, when you
Can you see the screen?
Yeah.
Okay, can you hear the sound?
Hi, this is Tom from ZeroToFinals.com.
Yes.
In this video, I'm going to go through hyperparathyroidism. By definition, hyperparathyroidism is a high level of parathyroid hormone. And there's three types, primary, secondary, and tertiary. And it's these three types that causes a lot of confusion amongst medical students and doctors. And it's the reason that I wanted to make this video, just to clarify what the different causes are. Firstly, I'm going to go through some simplified physiology. Bear in mind that in reality the processes are a bit more complicated, but for the purpose of medical school, everyday practice, and understanding hyperparathyroidism, this is all you really need to know. There are 4 parathyroid glands situated in 4 corners of the thyroid gland. The parathyroid glands, specifically the chief cells in the glands, produce parathyroid hormone in response to low blood calcium concentration. Parathyroid hormone acts to raise blood calcium level by increasing the absorption of calcium from the intestines, increasing the reabsorption of calcium in the kidneys, basically reducing how much is secreted in the urine, and increasing the osteoclast activity in the bones. Now remember that the osteoclasts are responsible for breaking down the bones and releasing calcium into the blood. The other player in the game is vitamin D, and vitamin D is a hormone that the body creates in response to sunlight, but it can also be obtained through food or supplementation. To simplify what vitamin D does, it acts on all of the processes that we talked about to increase absorption of calcium from the intestines, kidneys, and bones. Parathyroid hormone also acts on vitamin D to convert it into some of its active forms. So vitamin D acts basically alongside parathyroid hormone to raise the blood calcium level. A deficiency in vitamin D, as a result, could lead to a low calcium level. So let's talk about hyperparathyroidism. The easiest cause of this to explain is primary hyperparathyroidism. And this is just caused by uncontrolled parathyroid hormone being produced by a tumor of the parathyroid glands. This causes increased absorption of calcium and leads to hypercalcemia, which is an abnormally high level of calcium in the blood. And this can be treated using surgical removal of the tumor. The next cause of an abnormally high parathyroid hormone is called secondary hyperparathyroidism. And this is where either insufficient vitamin D or chronic renal failure leads to reduced absorption of calcium from the intestines, kidneys, and bones. This vitamin D or chronic renal failure leads to hypocalcemia, or a low level of calcium in the blood, and the parathyroid glands react to this low level of calcium by excreting more parathyroid hormone to try and compensate. Over time, the total number of cells in the parathyroid gland increases as they respond to the increased need to produce parathyroid hormone. This is called hyperplasia, and it leads to the glands becoming more bulky and secreting more parathyroid hormone as a baseline level. The serum calcium level will normally be low or normal, but the parathyroid hormone will be high in secondary hyperparathyroidism. And this condition can be treated by correcting the underlying cause, like the vitamin D deficiency or doing a renal transplant in patients with renal failure. The final cause of high parathyroid hormone is called tertiary hyperparathyroidism, and this happens when secondary hyperparathyroidism continues for a long period of time, and it leads to a big hyperplasia of the glands, and the baseline amount of parathyroid hormone that's being excreted by those glands increases dramatically. And so what happens is when you treat the secondary hyperparathyroidism and you remove the need for so much parathyroid hormone, the level remains high because those glands are so used to producing so much parathyroid hormone. What happens is this leads to a high absorption of calcium in the intestines, kidneys, and bones, and it causes hypercalcemia, or a high level of calcium in the blood. And we can treat this by surgically removing those big bulky glands and leaving just enough tissue that you get a normal level of parathyroid hormone. So to summarize the types, causes, the effects on parathyroid and calcium, and the treatment, primary hyperparathyroidism is caused by a tumor of the parathyroid glands. It causes a high parathyroid hormone that leads to a high serum calcium, and the treatment is surgery. Secondary hyperparathyroidism is caused by a deficiency in vitamin D or chronic kidney disease. The parathyroid hormone level will be high, but the serum calcium level will be low or normal, and the treatment is to improve the vitamin D deficiency or to do a renal transplant in chronic kidney disease. And tertiary hyperparathyroidism is a result of hyperplasia of the parathyroid glands after secondary hyperparathyroidism, and it leads to a high parathyroid gland, and as long as the cause of the secondary hyperparathyroidism is treated, it leads to a high serum calcium level. And the treatment of this would be surgery to remove the extra hyperplased parathyroid tissue. So thanks for watching. I hope you found this video helpful.
Okay, this is all about the summary. I hope you capture. Okay. Okay, I hope you captured this one. I think someone asked me why it is common in third and fifth decade of life. But remember, this is just an epidemiological studies, so it's more of related. This age group is where the patient is more likely having the chronic renal failure, what we have mentioned before. That is the most likely reason why it is actually very common in this age group. Okay, then the last session in the next few minutes, we're going to do a practice question. They are just very simple and related to what we have discussed. So you can actually even see question number one. Like a 60 years old smoker is found to have a 2 centimeter lung mass. There is a lesion in the right middle lobe, and the serum calcium level is like 13 milligram per deciliter. And there is no history of renal colic, and the most likely cause of this hypercalcemia is A, elevated level of parathyroid hormone, B, thiazide diuretics, C, overproduction of PTH-related peptide, D, bone destruction by metastasis. So what is your opinion? Now I am expecting you like your active participation, because this is just like the summary of what we have discussed. So what will be the most likely causes? So the calcium level is very high because the maximum, like the upper limit is 10.5 milligram per deciliter. There is no history of renal problem, which is good. So we just ruled out the renal causes. And the most likely cause of hypercalcemia in this patient is what?
I think it might be bone destruction by metastasis.
Okay, it can be bone destruction by metastasis. Any other? Any other?
What about overproduction of PTH-related peptide?
Okay, why?
Because of the lung lesion, and maybe that is lung cancer. So because of the malignancy, there will be a lot of production of the PTH-related peptide, which results in hypercalcemia.
Okay, thank you so much. So remember, the first person said bone destruction by metastasis. It can be, by the way, but there's nowhere in the statement like there is a lesion that actually metastasis to the bone. And so, because the information is just limited, there's a lesion, 2 centimeter lesion in the right middle lobe. So most likely, so that there is no metastasis. So this one is very likely. Thiazide is not even, the patient is not taking thiazide. Then remember what we have discussed. When a patient is having malignancy, there are two main causes of hypercalcemia in malignancy. The first one is production of PTH-related peptide. This ultimately work as exactly like that of PTH. Then the second one is increasing osteoclastic activity. And that is mainly because of bone destruction. So those are the two principal mechanisms. So this one is more of related to the most likely causes of this patient condition. So overproduction of PTH-related peptide will be the most likely causes. Now it is the same patient. Because of concomitant severe ischemic heart disease, the patient one is not eligible for surgery. So you can't do surgery. Then the most appropriate acute therapy, if the serum calcium level rises abruptly to 15 is A, sodium chloride infusion followed by loop diuretics, B, calcitonin subcutaneously, C, combination of A and B, D, cortisone, A, oral phosphate. Now, this patient cannot do surgery because of the other comorbid condition, and he's having severe ischemic heart disease. So he can't do surgery. So how do we manage? What is the acute treatment modality for this patient?
Calcitonin.
Okay, calcitonin can be an option, yes. So what about the role of sodium chloride infusion with loop diuretics?
Yeah, so the answer is
Yes, it can be both, by the way, yeah. So if a patient is actually having acute condition, what you can do is you just give diuretic, you give a calciuric therapy, that is normal saline with loop diuretics plus calcitonin, the most commonly used acute treatment when a patient is having a severe form of hypercalcemia. So both approaches can be used in the management of this condition. Now, the serum calcium level in a patient one after the treatment in patient two falls to 11.5. Now, after treatment or after acute treatment with calcitonin and calciuric therapy, like the patient condition or the calcium level falls to 11.5 milligram per deciliter. Now, what is the most appropriate chronic therapy for this patient? Repeat the dose of calcitonin, palmindronate, cortisone, oral phosphate. So what will be the most likely agent for chronic therapy of hypercalcemia?
Can you say the palmindronate?
Yes, yeah, mostly by the way, the calcitonin and other medication, what we have discussed, is more for acute treatment, but for chronic treatment, mostly the biphosphonates are the one which is actually commonly used. Like steroids can be used, but the major problem is actually the adverse effect with chronic use is not really good. Because of that reason, biphosphonates are the most appropriate chronic therapy in majority of patients who is having high calcium level. Now, question number 4. A 50 years old woman with multiple myeloma develops hypercalcemia. The most likely cause is A, bone destruction secondary to an increase in osteoclastic activity, B, an elevated PTH level, C, an elevated dihydroxy vitamin D, 125 dihydroxy vitamin D level, A, vitamin A intoxication.
I think bony destruction secondary to an increase in osteoclastic activity.
Why?
Because beta cells like the beta cells due to the multiple myeloma, the plasma cell disorder, they increase the amount of osteoclast in the bone,
Okay.
which leads
Okay,
to
good.
bone resorption.
Good. So in multiple myeloma, this is a plasma cell malignancies. So the antibodies actually produces a lot of cytokine. So this cytokine can actually causes bone destruction. That is why if a patient is by the having high calcium level, it is even good to check whether they do have this kind of malignancy. So this cytokine can promote osteoclastic activities. Then this ultimately causes hypercalcemia. In fact, this is one of the diagnostic modalities in this patient population when they're having this condition. So the answer will be A. So this is all I have for today about parathyroid hormone disorder, and it is not very common disorder. Okay, any question? You are welcome. Any question?
Sir,
Yes, yes.
when we say in primary parathyroid hyperparathyroidism,
Okay.
it's mainly caused by tumors. Is it all the tumors in the body or just the tumors surrounding the parathyroid hormone?
No, it is a tumor.
Parathyroid gland.
The tumor in the gland itself. That is why we call it primary.
Okay.
Yeah, it should be from the gland. Otherwise, there are so many tumor which is not related to cause high level of calcium in the serum. But malignancy can cause. Malignancy can cause, but not all tumors are responsible to cause high calcium level. But when you say primary hyperparathyroidism means there is a problem with the gland itself. That is why it is called primary.
Okay, thank you.
Okay, sawa. Then maybe
The app for Lexicomp is the one you have to pay for. So like the one you sent the link, it's the free one for the school, or
no, that is a trial. Like not really the owner, the one who is selling this drug information database gave us a trial version for 1 month to see whether it is relevant to our student or not. So relevancy will be assessed by the faculty members as well as by the student. I was just collecting feedback from the student. You just navigate all the options available in Lexicom by actually searching any drug information, and you just then make your own assessment. Even the video I shared will give you like the brief picture about the importance of this drug information database. Then after that, I will share the summary to the dean. Then maybe then the dean can consider to convince the management to have this database for our school. Yeah, for example, if I give you assignment about one drug, of course you can actually extract as many information as you want from Lexicon. Yeah, but even that the information is actually latest and current. That is the beauty of this, despite it is a bit expensive. So once I get the feedback, and the dean will actually look at like the feedback from the users, then after that he can make in a recommendation to the management of the university to consider to have this database. So that is the whole idea. So I encourage members, ultimately you will be the beneficiary of this database. I just encourage at least to go through maybe a maximum of 10 minutes, then make your own opinion. Because so far I received only like, is it 38 applicants, 38 participants from the survey. But how many students we have in the School of Pharmacy? I think like around 250, like even excluding the first year student. So maybe can you share to second year and third year student, because I don't have the WhatsApp group and I don't have any contact with them. Yeah, I share to the faculty member to actually to communicate with the third year and second year student, but I feel like I don't think so they have communicated. I doubt about their communication. So share with your network, then we'll see it, the feedback, so that we might have it accordingly, according to the decision from the dean. But what is the most important is the feedback. Okay, so please try if you can. Yeah, so maybe in the next few days, I think if I don't get any further feedback, I just share what I have.